And any questions from yesterday? No, I need to look at your crappy iPad. Kidding me? Your test isn't for another 3 weeks. Alright, so we'll jump back in. We're going to finish up the intro slides, and then we're going to go into some actual pathology and things like that in the other slide deck today. So this is where I stopped. I didn't cover this slide. So now let's get back into the mindset of ultrasound. Okay? Ultrasound is those sound waves, and we're able to look at abnormalities through that. What color, what is black on ultrasound? Fluid. Fluid, right? Good. So I have a cyst. How do I know it's a cyst? Well, I put the word cyst in it. So right there, right? We'll eventually learn that. But another tool you can use if you're unsure and you're like, hey, is this a solid structure? Is this a liquid structure? I don't remember. What the heck did that guy say up there all the way back in sophomore semester on iPad? I don't know. I was half listening because it was after lunch. Is this part right behind it? This posterior acoustic enhancement. Now I want you to look and see how much brighter white it is compared to the surrounding soft tissue around the cyst. Why is that happening? Because I have this fluid-filled structure. So the sound waves are coming in from the top, coming down, reflecting back soft tissue areas, energy's coming down, it hits the fluid, and it doesn't slow down the sound waves. They fly right through it, which is why it's black, and there's no response here, right? It just goes right through, no reflection. Then it hits that wall of tissue after the fluid, and it's got higher energy than surrounding it, so it reflects more of those higher energy sound waves back, so it looks brighter white to the transducer compared to surrounding, because it's been going through and slowing down the energy as it goes through all the soft tissue around it. So you get what's called posterior acoustic enhancement. Big fancy words for that's a fluid-filled structure there. And you can tell that because behind it you have that enhancement and it's brighter. Does that make sense from a physics standpoint? Right? It's another piece of information you can use for yourself when you're doing some of this stuff to go, okay, that's a fluid-filled cyst because of the posterior acoustic enhancement. Got it. On the flip side, we get posterior acoustic shadowing sometimes. So what this is, the red arrow, is a big old gallstone sitting in the gallbladder. Gallstone sitting in the gallbladder. So it's the complete opposite effect. The gallstone is more dense, way more dense than the surrounding tissue. So it's reflecting more of those sound waves back. That's why we can see that, which leaves less energy and less sound waves to travel through behind it to be able to give us a response. So we get a shadowing behind it. It's almost like you're standing in the sunlight and you have a shadow. The sun rays can't go through you, it creates a shadow on the ground. The sound waves can't go through the gallstone as well as the surrounding tissue, so you get this darkened shadow. So that's a clue that there's some kind of solid structure in an area that otherwise wouldn't necessarily be there, like the gallbladder. You get posterior acoustic shadow. Is that physics again? Does that kind of make sense in that aspect? So why is that important? Well, there's going to be times, and we're going to look at an image later on, where you're going to do the gallbladder ultrasound, you're going to look at it, and there's going to be this grayish kind of stuff in there. Gallbladder's filled with what? Bile, right? Typically a liquid, probably going to be black on most ultrasounds, but sometimes when that bile gets a little thicker, right, a little kind of agitated, maybe it's not a stone yet, but it's just kind of thick. I don't want to say mucousy, but we call it sludge in the medical field, right? You have this gallbladder sludge sitting in there. You'll be able to see that, and we'll have a picture on one of the slides later, where it actually shows the sludge in the gallbladder. Well, guess what the sludge doesn't create? It doesn't create the posterior acoustic enhancement because it's not a solid structure. It's still kind of that liquidy type stuff. It's just a little bit thicker and kind of annoying, so you see it in there, and you're like, oh, is that solid or is that just some sludge? Well, this is one of those hints that you can use. If it's solid, it's going to be a stone or the posterior acoustic shadowing is going to be some kind of stone or a calcified structure that's kind of stopping that because of those sound waves. Make sense? I hope. If not, let me know. Okay? We didn't really cover the crystals too much. It's really, they're just what reads the sound waves back. You'll learn more about the different crystals and the different transducers when you get into your senior semester and you're choosing which one to use for your EFAST exam. right? Just covered this, black, because it's fluid filled. Calcified structures appear brighter gray, brighter white, and it has that posterior acoustic shadowing, okay? Know this chart. This chart is important because when you're doing your EFAST in your senior semester and you're doing it out in the clinic, there are multiple modes on the ultrasound, and depending on what you're trying to look at, if you're not in the right mode, you're not going to get a good picture. Okay? So, alpha mode is the simplest mode, right? Mostly for the eye. That's what you need to know for alpha mode. It's mostly for the eye. When you use it in ophthalmology, you will do the eye as practice on each other in your senior semester. So, it's kind of cool actually. A gel squirted in your eye. Don't worry, it's water soluble. It's sterile, it's okay. You're a Cowboys fan? Is that what they were talking about earlier? I asked, and the only reason I had they called you out.
Cowboys fan, not a Jerry Jones fan.
That's okay, I can respect that. I mean, not the Cowboys fan, but hey, we're a product of where we grow up. It may not be his fault. All right. So alpha mode again for ophthalmology for the eye. Bravo mode, right? B mode. This is going to be kind of real-time motion, but really it's what's used for the most part in most of your ultrasounds. Sonograms, so like your babies is Bravo mode, gallbladders is done in B mode, that kind of thing. It can see real-time motion in the aspect to where what it's doing is like if the baby's moving, it can see the baby move, like we can watch that kind of thing. M mode is meant to show actual constantly moving structures. So what's the difference? One says real-time motion, one says shows moving structures, right? B mode is meant for things that can move, it can see that kind of stuff, like a baby moving in a uterus, okay? M mode is for those things that don't stop moving, primarily your heart and your lung pleura, the sliding of your lung. Those never stop moving. You're always breathing and your heart's always beating. You need M mode for that because it needs to recognize the motion, it doesn't get blurry for you. And on top of that, when we get into pneumothorax and looking at what the ultrasound looks for that, you got to put it in a certain area that's constantly moving, you'll hit another button, it'll show you a nice little picture, and you'll be able to diagnose pneumothorax with just an ultrasound. You don't even need an X-ray or a CT technically, but we will learn that. But M mode for heart and lung. Doppler assesses blood flow. Don't get it confused with duplex that talks about vascular studies with Doppler for structure and flow within a vessel. So we're going to break those down right now, okay? Doppler assesses blood flow. All Doppler does is tell you that there is blood flow to and from a particular location, okay? Testicles, ovaries. Do I have blood flow? So think about a torus testicle or a torus ovary, we're worried about that twisting on itself, stopping blood flow. I need to use a Doppler to figure out, is there blood flow going to this organ or not, okay? So that's what that tells you. The duplex is specifically to evaluate vascular studies. Deep vein thrombosis, I'm looking at the vein. I want to look at the main artery for some reason, okay? Doppler assesses blood flow going to and from a structure such as an organ like testicles and ovaries. Duplex is vascular studies. I'm evaluating the vasculature, not the organ. There is a difference. You can turn on Doppler with the duplex and kind of do it together, right? Just to kind of look at that blood flow a little bit to give you some more information. But the Doppler in itself is not what you use to evaluate vascular studies. It is duplex. They both start with D. They both deal with blood flow in different ways, which means it's commonly confused on the exam. Don't let it confuse you. If you have questions, let me know. Here's what some of these look like. So look at the Doppler in the upper left-hand corner. Get this out of your head now. Red does not mean artery, blue does not mean veins. All of our anatomy textbooks make the arteries red as oxygenated blood and make the veins blue just to make it match up, right? What the colors mean is red is blood flow coming towards your transducer, and blue is blood flow going away from your transducer. Which means if I'm aimed one way, and then I come and I put it in the correct opposite, my blue and reds are gonna flip, right? Because it's based off of transducer position. So when you're out there in the clinic, don't be like, oh man, the arteries are doing great, but man, we're having issues with the venous return. No, this is just showing you blood flow to and from. So what we care about is, do I have reds and blues perfusing most of the area? That means I have blood flow going to and from. That's what I care about. It does not mean arteries and veins on Doppler, okay? This M mode, what you're seeing right here, okay? This is a superficial area of looking at, this is area of kind of evaluating, it looks like part of the pleural lung area up here, but we'll talk about more about this, but this is the main picture that you're gonna do at the ultrasound, and then when you go into M mode, it like spreads it out so you can see the movement, and we'll talk about that specifically with pneumothorax when we get there. So just know that M mode is primarily for the heart and for the lung slide. Those are your two areas I need you to know. B mode looks at all kinds of stuff. This is the splenic vein, this is going into the spleen, trying to evaluate it. So any of the organs are gonna be your B mode. And then here's your duplex with Doppler. Okay, just to kind of give you an idea what that looks like. This is the duplex, so the thing on the bottom here is evaluating the vasculature, kind of the pressure and the squeezing of the artery, that's what those little things are. You don't need to interpret that or read that. I mostly need you to know what mode is for what study, so that way you guys, when using the machine for whatever reason, are set on the right mode. Here's one with a combination of the two. So it started off with duplex, and then they turned around and they decided to turn on the Doppler just to check for the flow. Now arteries and veins run very close to one another, right? And so that's why we got both of them here. But I can't tell you which one is which just off of this picture, because again, red and blue do not mean arteries and veins. Okay. So why do we use ultrasound? What are the pros? We get static and motion images, so right, we can get real-time images, and we can also take pictures with it. It's very cheap, it's mobile. They have them now to where you can buy one, download an app, plug it into your phone, and you can be scanning your patient while looking at your phone and looking at the ultrasound. Yes, butterfly, that's what they're called. They're not super cheap, so don't buy it yourself. What? Get your unit to buy them. Especially if you're gonna be like out in the field a lot, you can probably justify getting your unit to buy you one, so that way you can have it out there. No radiation at all. What are the cons? If you guys find one, let me know, right? Outside of accidentally being in the wrong mode or using it for something that it shouldn't be evaluating for, but that's just more user error in that aspect, there really are no major cons to ultrasound. I wish it could evaluate everything, it just can't. What do we primarily use it for? So any pelvic organ studies, male or female, right? Pediatric studies, which we'll talk about which ones those are, that it can see things like appendicitis, right? We're gonna try to do an ultrasound on that instead, because if I can get the answer without giving radiation on a kid, sign me up for that, right? Risk reward benefit. I don't have to give radiation to a kid, I don't want to. Some cases I have to. But we'll specifically talk about which pediatric studies when we get to those sections of the lectures in block 1 and block 2. Superficial lesions, that's where we showed you the skin one, right? Really good for you to kind of take a look if it's a cyst, kind of drain it if you want to. Non-invasive vascular studies, so blood clots and blood flow. So if you're concerned about deep vein thrombosis, we can use an ultrasound for that. That would be that duplex ultrasound. Pregnancy monitoring, we already talked about. Image guiding for procedures, we talked about that. Cholecystitis, what does that mean? Inflammation of the gallbladder, right? Inflammation of the gallbladder. If I'm just assessing for inflammation of the gallbladder, the answer is ultrasound. We're going to get into a study today where when I'm testing the functionality of the gallbladder, it's a different study, right? So don't get that confused. I'm just looking for cholecystitis, I'm just evaluating the gallbladder. I don't care about the function, I care because the patient has pain there, and I'm trying to evaluate whether or not the cause of the pain is the gallbladder in itself. Is it inflamed, is it angry, are there gallstones, what's going on? Ultrasound is your study to do that. And then fast exam, we will hit when we hit it, but you will learn about fast exam. Questions on ultrasound uses? Yes, ma'am. Yeah, so good question, right? It'll be more of a block 2 thing. The ultrasound can be used in the case of kidney stone patients, but you won't be able to see the stone. What you're actually doing is in your patients who have recurrent kidney stones, because we don't want to irradiate them anymore, looking at CT is usually the standard for that, but if like they're having like, hey, they've had like 3 this year or 4 this year or whatever, you can do an ultrasound to look at the kidneys to check for the effects of an obstructing stone. And we'll talk about that in block 2. You won't be able to see the stone, but the kidneys can give you a lot of information. Good question. What else? No. Patient positioning, doesn't matter. Lying, standing, sitting, right? It's a transducer attached to a cord. You guys can put it in whatever position you want to put it into. Ultrasound has contrast. What? You will never use this. You will never order this. These are super specialized studies. These are little itty bitty tiny micro bubbles of air that get thrown in there. Air is ultrasound's enemy in the grand scheme of things. We don't do a whole lot of ultrasound except for the right upper quadrant in the belly because there's too much bowel gas and there's not a whole lot of bowel gas sitting in that area. And then even then, if anybody's ever had a right upper quadrant ultrasound, they always tell you like, hey, fast the night before, don't eat anything in the morning because they don't want you to have a bunch of bowel gas causing issues. But in this case, they can put little tiny, and this is magnified, these are like microscopic, micro bubbles, and be able to use that to help kind of some of the ultrasound stuff. What do you need to know? You need to know that if somebody asks you what is the contrast used for ultrasound, the answer is micro bubbles, that's it. There's not a study in here that you're gonna talk about, that we're gonna talk about, that you're like, oh, you have to use the micro bubble contrast. We talk about contrast in every other modality, so it would be wrong to not mention it here. We just talked about the benefits, the uses. Any questions on ultrasound? I know it's split between 2 days. Yes, ma'am. Yeah, excellent question. For those that didn't hear it, is the posterior acoustic enhancement why they tell women who are getting their fetus ultrasounds to come with a full bladder? The answer is yes. The answer is yes. That's why women need to have a full bladder. It gets those high energy ultrasounds to be able to get to the baby and get better pictures. Yep. And every once in a while, they'll make you go to the bathroom halfway through the exam. Well, why is that? They got the pictures they needed for that. Now you can void and they can do some other ones. Or sometimes baby's not cooperating, and by relieving some of that pressure, baby will then move to where he or she needs to. But yes, that's exactly why you have a full bladder during the exam. Anything else? Okay. And since I see it right here, I forgot to mention, somebody had asked me on these intro slides, it's like, hey, chapter 21, chapter 5, right? No official chapter number, just find the information. On one of the slides, and I forgot to take it out, I apologize. I guess it has a comment in there, somebody brought it up, that it says, hey, you're responsible for the material in the slides and in the book. Don't worry about the book, okay? I am not pulling factoids from the book that are not in my slides. So everything is tested will be in the slides, will be directly on there, we'll talk about it in class. There's not a random sentence from the book I'm pulling out and be like, haha, I got you. I don't want to get you guys, I want you to understand the material and take it with you to junior semester where you can use it and be better in ortho and GI and all that stuff. All right, nuclear medicine. Looks a lot like the CT. It basically is, with one little caveat. So what nuclear medicine is a CT scan. They always do a CT scan first, nuclear medicine study, for some of these things. And then they will inject, see if I have it here, there we go. They will inject a radionuclide, which is basically a radioactive isotope that they inject onto something. Sugar, a protein, whatever the case may be. They attach it in a lab, and they bring it in, and they inject the patient with it. So now the patient is the source of radiation. And so what happens is, they scan, they inject, they get like a baseline, and they wait. And they wait for things to absorb whatever this molecule is, sugar, protein, whatever it is. Then they have special cameras that can read what part of the body is emitting radiation. And that's basically what nuclear medicine is in a nutshell, okay? Reference only, I'm not pinning you on, definition stuff again. Scintigraphy we will talk about briefly on the thyroid, so you didn't need to know that, but just so you understand the words that we'll be using. History sample, all the same stuff, right? Starting in 46, they first made the radionuclides, 46 into the 50s. By the time we got to the 60s, they started using them to actually map the blood flow of the brain. So they finally started being able to figure out all the different vessels we have in the brain, kind of map that blood flow. It was way more extensive than originally thought. We knew about the main arteries and things, but all the different branches and kind of how it flows. Nuclear medicine is what helped with that. By the time we got to the 70s, they found a way to do it with most organs in the body, because the catch with nuclear medicine, what was tricky about it is every organ absorbs a different product differently, right? At a different speed. Some likes glucose, like the brain. Other ones like proteins. Other ones like iodine, right? It just all depends. So it took them some time to figure out what are we attaching these radionuclides to, and on top of that, which radioactive particle do we attach to it to be able to get that organ to absorb it properly to be able to visualize it. That's what it looks like. It's basically a CT scan but fancier. Right? These extra cameras on the outside here, these big honking dealios, that's what's reading the radiation coming from the body. So we go back to our other CT scanner, it didn't have these guys on the outside, it just had just a donut. Got some extra scanners there for you. Here's what some of the things look like. We're gonna go over each of these, but different types of images depending on what we're evaluating, what we're looking for. Here's a YouTube video of how this thing works, if you're really interested. I got a YouTube working in here, just for fun videos too, but. Okay, so we already kind of briefly talked about it, right? Various body organs have specific affinity of certain chemicals, and that's how they figure out what we're going to inject. After it's carried to the tissue of the organ, it emits radiation, it gets measured and imaged using a gamma camera, right? It's not necessarily gamma radiation, it's what they call it. They call it a gamma camera. All studies the patient is lying down, just like a CT scanner. So there's no standing nuclear medicine scans, there's no sitting ones, there's no portable ones, or anything along those lines, okay? Here's what happens, right? The little weird kind of olive green triangular pentagon thing is the product, and then whether it's glucose, protein, whatever it is, and then the little scary sign is the radioactive material. They in a lab, they attach that radioactive material to the product. It becomes a radionuclide or a radiopharmaceutical. They inject it into the body. The cell has receptors. It has an affinity for certain things, different tissue, different affinities. It attaches to those cells that we were targeting, sometimes cancer, sometimes other stuff. And then that's how it blows up. They're like, hey, this is where this stuff is. Do not memorize this chart. You will need to know some of it for endo, but that's for endo next semester. But this is just going to show you what is the nuclide that we use for certain things. So I-131, you're definitely going to learn about that because that's thyroid stuff. I-123, you're going to learn about that because that's thyroid stuff. But you can see like with the heart, TI-201, that's different if we're looking for certain tumors or infections. All kinds of different things on this chart to kind of show you that it's not just one type of medication, we'll call it, or pharmaceutical to get this thing taken care of. Which means it's really important when you order your studies to tell the radiologist what you're worried about, what you're trying to get evaluated. Because they're gonna base what they give the patient off of what you're telling them you want evaluated, right? So that's where that will come into play. And we will talk about how to write orders during the lab portion of like how are we gonna talk to that radiologist to make sure I get what I want or make sure they fix a mess up if I order it wrong. Another example of how this works, right? The tumor, same concept as the cell. We can give certain ones to attach to tumors. The key protonuclear medicine is nuclear medicine evaluates function, right? It evaluates activity and function. You saw some of these pictures here. Not really good at looking at overall anatomy, right? For those that are wondering, this is the heart, these are lungs, this is the whole liver, gallbladder, biliary tree, right? The anatomy portion, it's not really made out that well. It's really hard to tell. but it's designed for functionality. What areas of these body parts are functional or aren't supposed to be and are functional? That's a sign of cancer or tumors. We'll look at some of that. But understand that when you're looking for functionality, nuclear medicine is what we're going for. What's the con? It's ionizing radiation, and the patient is the source. Which means when they leave, they are still emitting radiation when they leave the scan, right? These things have pretty good half-lives, and they'll be done within a day or so, a day or two of emitting the radiation. But important in your patient history stuff, you say somebody for a nuclear medicine exam, what if they're living with somebody who's immunocompromised? What if they're living with their daughter who has like a 2-day-old newborn, right? Giving them that counseling of like, hey, don't hold your grandchild for the next couple of days until you're done, just out of precaution. Are there any studies that turn around and show that the nuclear medicine patient went home and 2-day-old baby caught radiation sickness and ended up dying? Not that I could find, but we know that no radiation is safe, so we just take precautions. It's just 2 days, let's just be safe, that kind of thing. So patient is the source. There's your uses: thyroid, brain, bone cancer. We can talk about, we're going to talk about the biliary tree and things along those lines, and all different kinds of radiopharmaceuticals, right? Thyroid iodine, brain glucose, bone phosphates, makes sense. The bone likes phosphates. And then cancer modulators with the fluorodeoxyglucose, big fancy type of glucose. So what are the drawbacks? The only drawback to nuclear medicine that we had on there was patient is the radiation source. Benefits, functional assessment. It's the one radiology domain that we can do functional assessment over just anatomic. Yeah.
So when you say function, is like the function of the way the heart's working, the function of
Yeah.
the brain's working? Like
We're about to get into it. Yeah. Yep. Absolutely about to get into it. So when you say function, right? So what is the function? So bone scan we'll kind of look at a little bit, but myocardial perfusion. How well is the heart muscle, the cardiac muscle, being perfused with oxygenated blood? So I'm looking at the function of the heart and its perfusion with oxygen, right? Hepatobiliary aminodiacetic acid scan. HIDA scan. How well is the biliary tree and the gallbladder functioning? How well is it squeezing the bile out? How well is that going through the biliary tree so I can actually see if that's functioning or not? Is there a stone sitting in one of those ducts that's stopping the flow of the bile, right? That's the function of the hepatobiliary scan. Ventilation perfusion scan, or VQ. Don't ask me why it's a Q instead of a P. I don't know. It's just called a VQ scan, right? What is that? That's on the function of the lung exam. So how well is the lung being perfused when they breathe in with oxygen, oxygenated blood? We can look for clots that way if we have to. We'll talk about that. And then the thyroid scan also, how is the thyroid functioning? How well is that going? Where is the uptake there? So that's kind of where I get with functional assessments. And we'll look at each of these. A PET scan, the positron emission tomography, or the SPECT, both pretty much the same category. Those are your metastases, your cancers. Those scans are specifically designed to look for cancer, right? So what's functional about that? Cancer cells are going to be more active and more functional than other areas of the body, especially when we specifically give a radiopharmaceutical that is absorbed by the cancer cells. And so when you see it light up like a Christmas tree, that's functional of those cancer cells. They are growing, and they are alive, and they are doing bad things. So let's look at each of them. So bone scan / PET scan, right? So bone scan can be used for metastatic disease. It can also be used to diagnose a stress fracture. Big orange letters there. Can be used to diagnose a stress fracture. MRI is still your study of choice. Now, when you get to ortho uses different words. Ortho has their own language. Ortho is going to say, bone scan is probably the study of choice for a stress fracture. Okay? Why do we do MRI? A lot more of the places you're going to be working are going to have MRIs available and may not have a nuclear medicine department. So MRI for this course is your study of choice for stress fracture if you need to go there. That's what this picture is on the right. This is a stress fracture in the tibia on the right side. So you can see it's angry, it's highlighted because of the inflammation, the small healing, right? The cortical bone is trying to heal, it's being functional, yeah. Good point, right? We're gonna get to that, right? You are correct. X-ray for bone first, right? And yes, CT is better with bone than MRI is, right? But with an MRI, what I can see is I may not be able to see the fracture, but I'll be able to see the inflammation. So stress fractures are so small, and we will talk about this, that they're often missed on X-ray, right? And then so am I gonna give a bunch of radiation for a stress fracture on a CT just to diagnose it? Probably not, because what's the treatment for a stress fracture? Rest. So whether I see it on X-ray or not, the answer is just rest. I don't need to put a bunch of CT on you, a bunch of radiation in a CT to get that answer. Can I see it? Yeah, I probably could, but I don't need to, because you can just rest. But if it's chronic and it's not getting better, and it's not getting better, and it's not getting better, when I have a modality like MRI that can actually look for the inflammation of just that small minute fracture, and I know that even with the CT, it might be so small I still might not see it, I'd rather do the non-radiation study than the radiation study, right? It's one of the few caveats. I think I said it once here before, I never use always and never in medicine. There's always a small, like, well, except for this case. Bones, X-ray, and CT, except for study of choice for stress fractures is MRI.
So DEXA scan, same thing as a bone scan?
Say again?
DEXA scan?
No, DEXA is different, we'll talk about that later. Right? Words matter. Now, when you get out into the clinic, you're gonna hear a patient like, oh yeah, I had a bone scan for my osteoporosis. No, they really didn't, but that's what somebody probably called it, just because it was easy. But a DEXA does scan the bones, but bone scan is not synonymous with DEXA scan. They are different machines, different studies. And we will talk about a DEXA. So, but a bone scan is a nuclear medicine study. Okay? Bone scan is a nuclear medicine study. Don't worry about the isotope, it's on there just so you can have it, but it kind of shows you what's going on, right? It shows you that the areas of anger, so high bone turnover. Where do we used to see in high bone turnover? We see high bone turnover in the joints, that's normal, because there's inflammation, it's always healing, that kind of thing. It's the areas that we don't expect to see high bone turnover that kind of concern me. Or if you look over here, what areas are jumping out here with one compared to the other? Well, I got bilateral, so that looks pretty normal. I got bilateral, that looks pretty normal, anterior, right? It's the same on both sides. But then I sit here and I go, why do I have this on one side and not the other, right? Why is my spine highlighted posteriorly but not anteriorly? Things that kind of would jump out at me. Not gonna make you read nuclear medicine scans, I just want you to understand kind of what they're used for, okay? Heart, myocardial perfusion. How well is the myocardial muscle working and getting perfusion of oxygenated blood? Okay? How well? There are two ways to do this. If you're capable and healthy, they inject you with this stuff, they throw you on a treadmill. And they'll scan you after you're running on a treadmill for a while. And you'll get all these pictures. If you're in a wheelchair and you can't do exercise, they do it with medication. They'll pharmacologically stress out your heart by increasing the heart rate. And they'll inject you with medication. And then they'll send you through the scanner. This is all normal. I will show you what abnormal looks like here in a second. This is all normal, right? I want full perfusion from all different views of my heart. So everywhere you see color, that muscle is being perfused. It's getting the oxygenated blood because we injected the material and it's getting to where it needs to go. That's why it's highlighted. When it doesn't, here's my abnormal on the bottom. Gives you cuts in the different areas of the heart, but it shows you the difference between normal and abnormal. When you have the decreased signal or decreased color, that means those are areas of the heart that are not being perfused with oxygenated blood. So there's your difference between normal and abnormal. Okay. HIDA scan. When do we do the HIDA scan? Right? If you think you have cholecystitis and you've already done the ultrasound and it was inconclusive, right? Like, I didn't really give you what I needed it to give, then we can jump to a HIDA scan. if you think you have cholecystitis, the patient has it, and you haven't done an ultrasound yet, an ultrasound is first. But if it's inconclusive, your next study would be a HIDA scan. Another one it's really good for is post-operative biliary leaks. Why? Because it's functional. It's gonna follow that bile through the biliary tree. So, you have somebody who has cholecystitis, you ordered the ultrasound, you confirmed it. Let's say it's their third event within the past year, GI's like, yeah, we're gonna take that thing out. That's too much, they're having too many episodes. They go in, they surgerize, official word there, surgerize. They take it out, cholecystectomy. They put in the staples to block it off. Did those staples take? Did it work the way it's supposed to? Let's make sure. HIDA scan, post-operative biliary leaks. I want to see if there's contrast, or I should say radioactive material leaking out from where it should be, and make sure those post-operative flips are holding and they're doing what they're supposed to be doing. Okay? Bad part about this scan, these things take hours. This is not a fast scan, right? So that's why, another reason why we don't use it for acute cholecystitis, even though it can technically evaluate for that. I need an ultrasound done in minutes, right, once they get back there. This takes several hours to perform. But it is still the functional test for the hepatobiliary tree area is the HIDA scan for nuclear medicine. Here's your ventilation perfusion scan. It's the same concept. It's the same concept as the heart, all right? My normal scan is showing tons of perfusion in both lungs. It's dark black, it's not bright red, but it's still showing that perfusion. What's going on here? That's where the heart's at, right? So think about it. The heart's in front of the lungs. I'm lying on a scanner, it's absorbing. I'm the radiation source, so the radiation is leaving my body and getting read by the sensors. Well, guess what? The heart's absorbing some of that, and so it's not getting to the sensor, and that's why I have that little bit of white gap right there. It's not abnormal, it's just the fact that the heart's in the way with the way that the sensors of the radiation is coming, okay? But when you turn around and you look at this abnormal one, and I have these chunks missing, these are areas of the lungs that are not getting perfused. Okay? They're not getting ventilated or perfused. Oxygenated blood is trying to get to them, and likely there are blood clots in there that are stopping that blood flow. Okay? CT pulmonary angiography is the study of choice. We'll get into that more. But this VQ scan or ventilated perfusion is what you're going to use for pulmonary emboli, clots in the pulmonary vasculature, in patients that you can't give the CT to. Okay? You can't give the CT to the patients. It's a CT with contrast. You suspect PE, they got renal failure, right? Can't give them the contrast, they have renal failure. VQ scan. Okay? You're always going to initially order a chest x-ray to rule out other causes. We'll talk about that more in block 2, right? Chest x-rays first for just about everything. But you use the VQ scan when you can't get a CT PA for a pulmonary embolism concern or a blood clot. Thyroid scintigraphy. Alright? A little bit different than the lungs. The lungs, we're like, look how dark black they are, everything is good, perfusion. This is now testing functionality of the thyroid. How active is the thyroid? The thyroid is not a super active gland, right? It's not always going. So normal has just these kind of nice little white, black areas on there. Now, if I have something like Graves' disease, which is basically hyperactive thyroid for where you guys are at right now, you'll learn more about it as a junior, but it's super revved up. Look at how active, look at how functional that thyroid is. That's abnormal, okay? Or when you go down here, you'll see these little gaps, or like these little circular gaps, either brighter or darker than the surrounding thyroid tissue. Those are your nodules, okay? Why is this important? Well, if you see one of these things, you need to order a fine needle aspiration to figure out, is it a bad guy, is it a good guy? What's the reason for the nodule? You'll learn more about that in endo. Well, what's really important on this is it's the opposite of what our brains think most of the time. With the thyroid, most of your hot nodules are actually benign. Most of them are benign. When you would normally think, well, hey, look, this Graves' disease is more dark and that's abnormal, that's not good, it's hyperactive. So maybe this nodule must be a bad guy too. It's actually not. The cold nodules are more commonly malignant than the hot nodules when it comes to the thyroid. So you should be more pucker factor and more concerned about your cold thyroid nodules than your hot thyroid nodules. But the only way to do that is a scintigraphy for the functional assessment. How do I evaluate the thyroid otherwise? Ultrasound. That's the standard. Then we find the nodule, then we go, oh, let's get the scintigraphy. What kind of nodule is it? Or your thyroid's enlarged. Why is it enlarged? Is it Graves'? Is it just a large goiter that's not active? I don't know. We'll figure that out with the thyroid scintigraphy. This checks the function of the thyroid. Here's your PET scans. Okay? Primarily looking for hidden metastases. Bottom line, you got a new diagnosis of cancer. You got a patient with a new diagnosis, just found it. The next thing is, I need a PET scan. Why? Because it isn't anywhere else. This is the best way to do it. They get their CT, they get injected, they wait a little while, they do the PET scan. Okay. So the PET scans are for cancer progression, reoccurrence. So the people that are in remission, when they're going in every 6 months or whatever it is, they're getting these to make sure nothing highlights that wasn't on the last one. This, unfortunately, is a patient who had lymphoma, and it got into the majority of their lymph nodes and lymphatic system, hence, not the skull part, but all of this. Right? Most of these are going to be ordered by the oncologist, right? But if you're the one who finds the cancer, which is very possible, the initial cancer, you're going to order this right away while you're putting in your referral to oncology. So that way they already have it. This one's FYI, you don't need to know about this one, right? But they're even getting to the point to where they're starting to use nuclear medicine studies to actually like map out the brain and using it to look for certain things like seizure disorders, dementia, like evaluate for certain blood clotting disorders, way above my head, but like this is something new that they're even starting to use to be able to really break these details. Again, ordered mostly by a neurology specialty, they're not gonna interpret these, but it's just something that's new and up and coming on nuclear medicine stuff. Right. Again, this is what those ventilation perfusion scans look like. Not going to make you necessarily read these or dictate these, but you need to know when to order them and what they're used for. Same thing here, right? I got perfusion issues, and this is why we stress out the heart. Because at rest, everything looks nice and perfused. Get that heart rate going, completely changes the way the scan looks. So this is why they throw the patient on the treadmill, or they do the pharmacological way to get their heart rate up, so they can get a true representation of what that heart's looking like when it's being stressed out in a high heart rate, because it does change the view. We just talked about nuclear medicine stuff, right? Bone scintigraphy or bone scan. Bone cancer in the femur, that's what that is there. Bone lesions are called fractures bone scan, right? Going over this lung perfusion, the VQ. Thyroid scan for the thyroid scintigraphy is the name. HIDA scan for the liver, gallbladder, and bile duct, the functionality aspect of it. Myocardial perfusion scan for the heart. What does cystic structures look like on ultrasound? What color?
Black.
Black, because they're filled with fluid. Good. Calcified structures, white, and has the shadow that forms behind it. We already went over that. Inexpensive, mobile, no radiation. You got a whole slide on those uses. Talked about that already. Like I said, I'm not going to belabor the new slides. They're there for you to review when you're studying, because we just talked about it. Major benefits, functionality, and some uses. Questions on any of the intro stuff? Yes, sir.
Are the dates important?
No, none of the dates, none of the history of like when stuff was invented, Nobel Prize, none of that is I'm gonna test you on. Not important for you as a clinician.
Why would you wanna do the thyroid scintigraphy? Isn't there, like, couldn't you just test someone's T3, T4 to figure out the
So all that-
functionality of the thyroid?
All that does is tells you if there's a problem with the hormones. That doesn't tell you why, right? So you can do the thyroid labs as an overall kind of like, how are the hormones being released and what are the levels to go, is the thyroid functioning normally or is it abnormal? But it won't tell you what the cause is. I'll give you an example. If you have hypothyroidism from your labs, why? What's going on? Is there a mass there that's causing it to not decrease it? Is it a pituitary issue? Is it a thyroid issue? Is it just that it's kind of, is it crapping out? You'll learn in endo about the like negative feedback loop and all that jazz. All that is one piece of information. So once you notice a physical abnormality in the thyroid, i.e. it's too large, there's a mass or something, that's where the scintigraphy comes in to get more information. Yeah, good question. What else? Take 10, come back at 25, 27, 20, yeah, 10 minutes now. Come back to 10 minutes. I didn't do it math. As you get better at doing it, you'll see stuff, but it just won't be clear because you'll be like, you'll see that one this week. So first, it's the code actually doing more stuff. Someone asked you questions on it. Yes. Very rare. It's not a silly can't, right? It's just not required. It's not being forced. It's not just because think about it. Where your kids and where you're I don't even care about kids as a college. Where are they at? You're sitting right here. What else is here? Watching a bottle, which has gas in it. Sound waves don't travel well through the air. And so that's why it's not a good study to evaluate for sometimes maybe, right? But if I'm doing a study, I want a study that's going to give me the answer. Sometimes it tells me what's there, but sometimes it doesn't tell me what's there, right? Why are you asking me? Like doing Excel stuff? So again, kidney stones or urinal stones, right? So it's a misnomer. Kidney stones and kidneys can absolutely be seen. When we talk kidney stones, we don't care about the stones that are sitting in the kidneys from a medical standpoint because they're not causing clear symptoms. It's when they fall into the ureters, you start getting that pain on your kidney stone. And even though we still call them kidney stones as a technically so, yes, things that are sitting in the kidneys, very well but don't sound like that. Kidneys are right now, all that bile is not going to work. When I go to urinators, which is the ones that we're watching as a look at providers, that's where you see the kidneys are just such a broad term. When you have one that's passing, like, oh, you got a kidney stone. Technically, what's in the it's a bigger stone. But we just call it kidney stones. Yeah. Is this thing even picking up like my little? It is? Okay.
Makes it easier to go back and get stuff.
Yeah. Oh, we get to actually like looking at the here soon. Actually, I'm going to use the pen because it's working now. You guys are lucky. Past 2 semesters, it wasn't calibrated. I couldn't figure it out. It would draw like 3 inches to the right, and I'm like,
Same way in the first class.
yeah, I was like, I can't use this because like I can't. I feel like guess, and it just didn't work. What's up?
First one, so like typical there's obviously like this.
To be honest, you're good.
Well, yeah, I mean, people are like,
Talk to the juniors?
well, no, like it's fine. I need to know, like, if they're estimating it.
So it's twofold. How it announces it. I'm sure that if you're saying it, other people are going to start on it too. So I'll address that.
So next,
Yeah. You have to address it, right? Don't deal in absolutes. If I tell you that this is the answer, this is the answer academically, and you got to know that, bring the shit on. Alright? Look at the space going on, so let's go now, look at your friend. Either one is fine. put both those answers on there because they both can technically be used for many things. What is your clinic capability? Because you can get a nose skin, but not have the capability to then you go nose skin. Either one is going to be okay. If you have a PET scan available, I would order the PET. It's better. It's more detailed. It would be the preferred method. However, not everyone has a PET CT scanner, and you have to go to
Yes.
It's just same same concept. One like spec is the one that's like the newest and the greatest, more expensive, and awesome. But really, they both do the same thing. One's just depends on what you got. You're either going to have a PET scanner or a spec scanner. You won't have both. Yeah. All right, let's take our seats. Let's get started. Had a question over the break more about the course and the fear and the stigma and the radiology scary and it's gonna fail all like a third of you and all that. I'm paraphrasing, right? It's not. But the question was why? Why do I think radiology has the stigma? And I said, well, if one person is thinking this, then there's probably at least 15 of you, if not 65 of you, that are wondering the same thing. So I will tell you why radiology gets the bad rap and the stigma. It has gotten better since I took the course over a year and a half ago, right? But part of the reason is, first of all, you guys have already seen it. We haven't really dove into really reading the images yet, but it's really abstract. So for those who have never looked at this stuff before, it's like you're trying to interpret art in an art museum, right? You ever say looking at a video, you're like, yeah, it's pretty. You're like, I don't know what the hell he meant, right? I can't feel somebody else like, oh, look at the brush strokes, and it's like this way. That's what I'm trying to teach you guys to do. So that, in general, puts some fear and some lack of confidence into you guys with that, right? So that's number one. Number two is the first test usually goes pretty well because I have those intro questions, right? Along with reading MSK stuff. There are some challenges to it, but in the grand scheme of things, as we break it down, it's not as challenging as chest and abdomen. So test one goes pretty well, which then goes, guess what happens to those of you who are gonna get the 92, 90, 94 on test one? You're gonna be like, sweet, I got this buffer, right? This feels good. And I got farm coming up, and that first farm test kicked my ass. So I need to focus on farm more than I need to focus on radiology part 2. And I have this buffer. And then you overestimate your buffer, and then on block 2, you end up with like a 56. You studied well enough to get like a 75, because you still want to pass the test, but then maybe you didn't study in the details because you were focusing on one, and you had this buffer, and then you do a lot worse than you meant to, and it's only a 2-block course. So that's another pitfall that we end up getting into. So if you do well on the first one, yeah, you have a buffer, but please give it the attention it deserves in block 2, because on top of that, I don't have those intro questions, right? So if 30% of my ballpark, I didn't make the test yet, I don't know what percentage of it is, but if 30% of the test is from the intro slide decks, that's 15 questions that are first order, single line toss up. What color is this? What do you use this for? Something along those lines, right? I don't have that on test 2, which means by nature, when you have to replace it with actual material and not intro material, that test is going to be more challenging than the first one because I don't have that to use. Does that make sense? So that's usually what we end up seeing, is what is the causes. One is the abstract stuff, it's kind of hard to kind of swallow, but really it's the buffer zone and then not doing well on the first one, or actually, believe it or not, the people who don't do so great on the first test tend to do better than some of the people who do really good on the first test on the second exam, because they don't have that kind of sense of comfortability when it comes to it, right? Ask questions, come see me on break, come see me in my office, send me an email in Canvas. This stuff can be different. I'm gonna try to break it down to like a level to where you guys can see what I'm seeing, but if it's not clicking, let me know, okay? Nobody failed this class last semester, okay? So talk to the juniors, don't talk to the seniors, they're special, right? They're special, don't talk to them, yeah. And they only had one, right? And so it's not this, talk to people at phase 2, they're gonna tell you, oh God, radiology, right? But it's not as daunting as it is. That being said, what I said here with that first block, second block stuff, that 2 test stuff, applies over there when you have pulmonology, endocrinology, neurology, gastroenterology, that are all 2 block courses, right? Don't get complacent with that. And the biggest thing is, come and see me. I'll be happy to break it down. If you're having issues with radiopedia, come ask me, right? I'll help you find the stuff. I want you guys to be able to read these things when you get out there. Because what's gonna happen is if you don't, is you're gonna misdiagnose somebody, or you're gonna overlook something that's actually there, and you can get the patient care sooner, right? For example, with ortho stuff, there have been multiple times when I've gotten people into ortho same day as they came in to see me for the x-ray, because I didn't wait for the radiology report. I saw it, I saw pediatric, Salter Harris, you'll learn about it in this block, and I was like, oh, it's right there, I'm not waiting for the radiologist. I got ortho on the phone, they got them in that afternoon, an hour later, to start their surgical planning and assessment. Had I just sent them home and had to wait for a radiologist 2, maybe 3 days, then you call, oh, there's a weekend there, right? We delay that care. So you can really expedite the care if you get good at reading this stuff. Questions about that? Concerns about this course? Besides the ones you have internally? Alright. Let's get into the actual part of looking at the bones, going over our stepwise process, finding pathology, okay? And talking about why it happens. What kind of bone is that? Right, spongy bone. Looks pretty good, is that look healthy? Sure, have we ever seen a picture like this before? No, so how are we supposed to know, right? How am I supposed to know that that looks healthy or not? I don't know, but when you compare normal to abnormal, all of a sudden you go, oh, that's not right. Why do I show this? This isn't an x-ray, right? This is like a electron microscope thing of like the spongy bone stuff. Why do I show that? To drive home the point. Staring at this, staring at normal when it comes to x-rays is how you get better at reading these. Looking at normal. Same thing with your clin skills. Why do we have you guys listening to everybody in here when you're doing your heart and lung listen or your physical exams and not actual sick patients? Because you don't know what abnormal is until you know what normal is. You listen to normal 1,000 times, then when something comes in that's abnormal, you're like, oh, I may not know what, but I know it ain't right. Same thing with imaging, right? Looking at lots of normal will help you go, oh, wait a minute, what's going on here? That's not what I'm used to seeing, okay? And that's how I want you to treat this as you're looking at these pictures, as you're looking at these images. Get comfortable with normal, so when abnormal jumps out, then you can kind of figure it out and what's going on. Because the majority of the stuff you're gonna get in clinic is gonna be normal. Most of your patients are gonna have normal imaging, right? So it gives you that confidence to send them home, and then the confidence of when to dig deeper when there is something going on. All right. So in this block, and we will not get through the entire thing today, right? 116 slides, lots of pictures. We're going to talk about ordering studies, how to read the images, and then we're going to start getting into some of the abnormalities, okay? So, how do I order the study? SBAR, Situation Background Assessment Recommendation. We've all heard this before. I think you heard it in your freshman semester. A lot of us have probably used this in our other jobs. Even if you were at medical, there was some form of this in almost every career field, right? Of, hey, here's what's going on, here's what happened, here's what we need to do to fix it. Or because of, bless you, because of that is what I think the story is, and here's what we gotta do to fix it, right? So that's what you're gonna put in your reports, or in your orders, right? Patient provider contact, that's gonna come automatic from the electronic health record, great. Pain, not helpful. Not helpful, right? More information on radiologist count guide study. So if I just say left elbow pain, great, they're gonna look at, now they have to look at the whole thing, but they're just gonna look at it and be like, yeah, I mean, that's fine. But if I say 14-year-old male having lateral left elbow pain over epicondyle from fall 3 hours ago from monkey bars, or from 5-foot fall 3 hours ago. Now all of a sudden I'm telling the radiologist, hey, it's elbow pain, you gotta look at everything, but I want you to pay close attention to that lateral epicondyle because that is where they're hurting and it just happened. right? You will get a better read. They'll probably still say, please clinically correlate, right? Because that's their legal way of going, it's your patient. But you will get a better read from that, as opposed to you just put pain, and then they're like, yeah, it looks normal. And then you're looking at it going, well, that doesn't look normal. Now I gotta call you and be like, are you sure? Well, you had the benefit of the patient sitting right in front of you. You knew why you ordered it. Tell them why you're ordering it. Flip side, think about CTs. There's contrast, there's without contrast, there's pancreas, there's liver. We're gonna talk about all that stuff, right, in the second block. What happens if you screw up the order and you accidentally order a non-contrast instead of one with contrast when that's what you really wanted? How are they gonna catch it if you just put abdomen pain? They won't. But if you actually write out a short, like 1 to 2 sentence description of here's what's going on with the patient, right upper quadrant pain, ultrasound already done, ruled out, whatever, concern for liver abnormalities, please evaluate and treat. And you actually order a non-con, they're gonna get that in the radiology department and read it, and they're gonna go, that's weird. They're gonna take it to the radiologist, the radiologist's like, yeah, no, we need that with contrast. They'll change the order for you. So that means the scan gets done right the first time. But if you just put abdomen pain, they're just gonna give you what you asked for, and then you're gonna get the study and be like, well, that wasn't helpful. Now the patient has to go back because I misordered the study, right? So that's where that comes into play. So give a short little S-bar. Not much, they don't need the whole story the patient's gonna give you. It's gonna take time, but, all right. When you're reading the images, right? First, make sure you're looking at the right patient, the right body part. If you're expecting to see Joe Smith and his left shoulder, make sure it's Joe Smith and his left shoulder, and the right birth date, right? Make sure it's the right views. Use your systematic approach, same approach every time. Describe what you see in your head. If you want to say it out loud, that's fine, it's just your office. Somebody walking by might think it's weird, but you do you. When you find something, you find the shiny toy, you get excited because you found an abnormality, and you're like, I learned something, I did it, yes. Don't stop. Keep going through your process. If you find the shiny toy, you may end up missing something else that is pertinent to the case and their treatments, right? So, we saw this one already before. Now that we're getting to the point where we're gonna start looking at these things, I'm gonna do some drawing. So correct patient, correct image, we're just gonna assume that already happens, right? You look at that, you're good. So the first thing I do, I then follow through my cortex integrity. So that's the cortical bone. So on every bone on this x-ray, I am going to, with my eyes, I am going to follow this bright white cortex all the way around. And make sure that there are no gaps in it, right? I'm gonna go through and look, and then, oh, I don't know what that is. Okay, cool. So I'm gonna note that, and I'm going to move on. I don't stop at the forearm, even though it's the forearm x-ray. I have carpals here that I'm tracing with my eyes. I have metacarpals here that I'm going through. And what I'm doing is I'm following the bright white of the cortex to see if I see any gaps, any radiolucent lines, anywhere along those, just following it all the way through, right? So on this one, right, there's my shiny toy. So now I'm gonna show you like, oh great, the forearm's broken. If I stop there, what I would have missed. My next thing, my medullary texture, whether that's the spongy bone, medullary bone, cancellous bone, depending what bone it is, right, they have different names, but it's more the inner part of the bone, those areas there. I'm following that with my eyes. Do I see any radiolucent lines through there? Do I see any masses, any abnormalities? Well, what's normal look like? Well, normal looks like that right there. And the more you see it, the more you'll see normal. And then it will jump out. When we look at osteoporosis, you will see the difference in the density of somebody who has got normal bone density compared to somebody who has decreased bone density. You're gonna go, oh, would you have caught it out if I just gave you an osteoporosis x-ray? Not right now, because you haven't seen enough normal yet to know what it's supposed to look like, right? So, medullary is next. Then I look at joint alignment. This is where A&P, anatomy and physiology, really come into play. Are my joints, and I kind of do joint alignment and joint spacing together, right? Are my joints where they're supposed to be? This includes the carpal joints, the metacarpal joints, every joint that's on the x-ray. Is everything lined up appropriately? And this is where, if I got excited about my shiny new toy, I would have missed a couple of things. because I can tell you that my radius is lined up very nice. But what's going on right here with my ulna? That's not supposed to be there, right? That should be sitting right here with the radius. It's not. So now I have a dislocated ulna at the distal end, which would have been overlooked had I just seen the fracture and said, oh yeah, you fractured your radius, which is true. The ulna doesn't have a fracture on it. And on this picture, it doesn't look dislocated because it's only a 2D. But when I get my orthogonal views, now I see it's dislocated. Also, I got this weird floating kind of carpal sitting right there. Now that pisiform does stick out just a little bit, but not that much, right? And you'll see that when you get to the normals. So there's my joint spacing and joint alignment. So now I found the dislocation. Then I look at my surrounding soft tissue. And we looked at this one already. My surrounding soft tissue right there has that little gap in it. This should be a nice smooth line like it is here. Tracing that soft tissue down, nice and smooth on both areas. I don't see any foreign bodies. I don't see any gaps in the outside world. But when I do this one and I trace it down, boom, boom, boom. Almost looks like a shark tooth shape kind of sitting right there in that soft tissue. I'm going to erase it now. I'm going to draw it again. Right? So what does that tell me? It was an open fracture, correct. Right? That bone fractured, popped out, caused that divot in the soft tissue, went right back into place. That's an open fracture. Now again, you're going to tell me, well, I would know that because I'm going to see the patient, I'm going to see the opening, and see the blood, unless you get this image before you've seen the patient and said it's like the ER, the urgent care, or something along those lines, right? Or you're following up on my patient, and you're looking at their x-rays from a week ago or 2 weeks ago when I found it. And you see that and you go, oh, open fracture. Let me go back in his note and make sure that numbskull actually gave antibiotics to treat the open fracture, because if I didn't, now you need to, because that's the standard of care and treatment for something like that, right? So that's where that comes into play. And then finally, area of concern last, right? If you know they hurt over the proximal radius or in the radial head, look there last, so you don't fall into that tunnel vision standpoint of, found it, I knew it was wrong, there it is, and then you forget to look at everything else. That's my process. You can do it in that order. You can do it whatever order you want. You can be like, I like joint spacing. Great, do joint spacing first. I don't care. What's important is that you hit everything and you do it the same way every single time. When you do your physical exams down there for clin skills, right? As long as you hit it all and you do it the same way every single time, order doesn't matter, right? There's a recommended order because head to toe is easy to remember. But if your brain works differently, as long as you don't miss it and you evaluate everything, do it in whatever order you want, right? Just do it the same way. Questions on that? Okay, let's talk about some of the vocabulary and talk about evaluating this stuff. So cortical bone, we already talked about. Cortical compact, interchangeable. Okay, interchangeable for this course. Same thing with cancellous, spongy, medullary bone, trabecular bone. They all mean slightly different things, but because it depends on what bone they're in and everything, but interchangeable here. I care that you're looking at the bone that is a little bit deeper than the cortex, that medullary area, that spongy bone area. It is different name depending on if it's a flat bone or it's a long bone. Not getting hung up on that. I just need you to evaluate that stuff, okay? So you'll hear me use the different names throughout this, just for, because everybody calls it something different, so I do that just so that way everybody kind of gets a piece of whatever word they want to use. But for this course, they're all the same. Epiphysis, diaphysis, metaphysis. We will talk about that more specifically when we get to the Salter-Harris. Okay, the epiphysis is going to be obviously the end of a bone. The metaphysis is another area that's in between that and the growth plate. Diaphysis or shaft of the bone, right? We'll talk about all those different things. Sclerotic. Okay, sclerotic, becoming rigid and unresponsive. Also interpreted as scarring. Okay, sclerotic is scarring. So if I'm rigid and I'm scarring, do you think I'll be more radioopaque or more radiolucent in the surrounding bone? I think more radioopaque. Correct. I'm thicker, I'm hardened, I'm scarring, and we'll see some of that. Lytic lesions, lysis, destruction. So therefore, more radioopaque or more radiolucent than the surrounding tissue and bone. More radiolucent, things are dying, right? They're lysosine, you're gonna have less density, good. Osteoblasts we know create bone. Osteoclasts we know absorb bone. Okay, there'll be a couple of these conditions where it looks a little weird, but it talks about like what's more active, the osteoblast or osteoclast, and why. Osteopetrosis is a rare inherited disorder, which we'll look at pictures on that. Osteonecrosis, death of the bone. Bone can die in multiple ways. The main way that we will look at it is lack of blood supply, and we will talk about that. Osteoporosis we will cover extensively. Osteomalacia is an interesting concept. It's a softening of the bones. So if the bone is softening, do you expect it to be more radiolucent or more radioopaque than normal? More radiolucent, that is correct. However, what's interesting about it is the telltale sign of this is actually going to be radioopaque lines, and we'll talk about why we'll need to get there. Okay. And then osteomyelitis, this is what happens if you don't give antibiotics to an open fracture, right? It's an infection, inflammation, and infection of the bone or bone marrow, usually due to an outside source, but you have ways to stop that. And those are some of the things we're going to look at. We're going to cover bone composition and all these fun things. Okay. These are the slides I was telling you about. Straight for your anatomy stuff, just a reminder of what makes up the bone, what the anatomy is. I'm not going to belabor this, but it's there for you so that way you don't have to go back to previous class lectures to try to pull those anatomy slides over, okay? Try to make it convenient for you guys. Oh, that's seen that before. Really know that. Not just for the test, but for life as well, in clinic as well. All right, so there's our cortical bone, right? That thickened white outer portion of the bone. It's not always this thick. I use this one because it really stands out compared to that other bone, right? Sometimes it's really thin, but it's always going to be more radioopaque on normal x-rays compared to the medullary spongy bone on the inside. More radioopaque. So what you're doing is it should be this nice, smooth, radioopaque, whitish, light gray line. You shouldn't have any radiolucent lines through it. There will be signs of fractures. It should just be continuous all the way up and down. Excuse me. Your medullary bone, a little bit more radiolucent than your compact bone. The biggest thing with your medullary bone, you're like, well, how do I evaluate that? How do I know how radiolucent it should be? When you look at more normals, you will get there, right? The biggest one is going to be osteoporosis, which you'll be able to pull out when you start looking at more. But doesn't look the same throughout, right? This whole bone doesn't look the same all the way throughout here, around the same density, around the same makeup. In this case, the answer is yes. Can you see any horizontal or vertical radiolucent lines that are like in a certain area that don't go throughout the whole bone that kind of make it look like it's might be an abnormality there, but you want to evaluate all this. Very rarely do we have fractures in just the medullary bone and not in the compact or the cortical bone. Very rare, but still gotta look just to make sure. Here's officially cancellous, right? Looks a little bit different than medullary, but that's why I say this. It's the inside. I'm going to use interchangeably, okay, depending on the body part. Just going to throw it out there. For this course, I don't need you to be like, oh, well, cancellous is in the hip, but the medullary is in the tibia. Don't care. It's all the bone on the inside. Okay. Reminder that osteoblast is new bone formation. Osteoclast is reabsorption of old bone. And all of these things can cause changes in bone density. Right? Cancer, obviously. Hormonal changes. So what patient population do you think we're mostly talking about there? Postmenopausal women, right? Postmenopausal women. They end up getting more indicated for osteoporosis because of the hormonal changes. It starts affecting the calcium reabsorption of the bones and all of that. So that's why they have medications for that kind of thing, and that's what we're concerned. That can affect bone density. Genetics is genetics, that's self-explanatory. Vitamin D deficiency, what's that disease called?
Being an iPad student.
What was that?
Being an iPad student.
Being an iPad student? I hope not. act like you're in here like 12 hours a day with the lights off. Come on, it's an outside building. You get vitamin D every time you go on the way. Rickets. If anything, there's other malnutrition that would be better for IPAP students. Sleep deprivation, maybe. Not necessarily vitamin D. Renal disease, right? Kidney disease is going to affect your calcium reabsorption throughout the body, so that can affect bone density. And then blood flow. Either too much or not enough. Primarily in this course, not enough. If I don't have blood flow, then it's not getting the nutrients it needs, right? Here is a chart of the things we're going to go over in this lecture. If it says FYI, I'm not testing you on it. But why not? Why do you waste our time covering stuff that you're not going to test me on? Because you're going to see those disease processes in other classes, and they're going to give you images, and I don't want that to be the first time you see something with it. Right? So I'm not going to give you one of these because some of these things, you need quite a bit of patient history to kind of pull out, which you will learn more in the ologies. But I don't want that to be the first time you see that x-ray and you have no clue what you're looking at. So, but you can see how it's broken up between generalized and focal and increased or decreased bone density. Okay? Let's start off with, look at this. If I have two and one's FYI, only one of those is testable. Right? Watch those things. And I tried, use that chart primarily, but I tried like even putting FYI on the disease processes that are FYI in the chart as well. I think it's all nailed down pretty good. If there isn't, you find one, bring it to my attention. But the first one, diffuse osteoblastic metastases. Diffuse metastases is cancer, osteoblastic, it's creating more bone, right? So it's an increase, generalized increase in bone density. The image on the left is normal. Almost all of these, if I have a left image and a right image, the image on the left is normal. If it's not, I will tell you. This is designed to help you see normal and help abnormal stand out even more. Okay? So, diffuse osteoblastic metastases. What is going on? Right? And so, I'm glad somebody said that. They're not holes. These circles, and that's a good thing to bring up though, right? Because they're not. What's going on here? These are more radiopaque. These are masses. This is something that's there that shouldn't be. It's not an absence of bone. It's an increase in density. Right? Now, if you see something like this, God, I hope this is not for the patient. This is not the first time somebody finds this. They had cancer somewhere else and it has metastasized to the bone. It's probably all over their entire body, but it's got these cannonball, radiopaque stuck all over it, right? Now, I have full confidence that pretty much everybody in here, if I gave you just this x-ray on the right, day one coming in here, you would all be able to go, that's not normal. Even if you've never seen an x-ray before. Pelvis is not supposed to look like that, right? And that's good. But I show you the normal so you can practice the normal as well and have it really stand out. So sometimes you might see this, and then your next question, if they don't have cancer in their history, they do now. You just got to find out where it's at. I don't know how else to say it. But what if this patient just came over? What if they just they've been sick for a while. They just PCS. They just married somebody in the military while they were on tour over in Southeast Asia or something like that. They haven't had health care their entire life. They come in, they got some pelvic pain, they've been sick for a while. You get the x-ray to kind of see what's going on, and this comes back. Guess who's now got to go on a hunt for where the main cancer is? You guys. You got to figure it out, right? So it's a hint to know, okay, that's what's going on. That's your diffuse osteoblastic metastases. It's a bunch of cannonball, bright, white, radiopaque, okay? Then you run into this. Again, normal on the left, abnormal on the right. This is osteopetrosis. This is an autosomal recessive genetic disorder, extremely rare, but the entire bone, the entire skeleton, all the bones, are going to harden and become more dense. Bones, when they get more dense and hardened, become actually more brittle. You're probably going to see this in your kids. Usually this is found in kids, because as they start growing, the bones don't stop getting more dense, and they'll start having leg pain. And so this one you may just find by an x-ray. Right, they're coming in, getting a fracture or something like that, and you order this. And it's the entire bone. All bright white. It's the only genetic disorder we talk about. I think it's one of the only ones that literally is affecting the entire skeleton like this. Yes, sir?
What's that radio thing?
I was getting there. Good question. Anybody know what this is? Should the bladder look like the bone? Bladder's soft tissue, right? Yeah, there it is. So it's a lead shield, is what it is, because this is a female patient, and they're trying to protect the uterus and the ovaries from the radiation, and so they put that there. Now the catch with that is that if it was a male, it would be down in this area. If it was a male, to protect the testicles from the radiation. The problem with that sometimes is, in this case, not a big deal because osteopetrosis, is that sometimes if you're trying to evaluate the pelvis, you're not going to see that. Why? Because it's going to hide the bone, and I need to look at the bone. So in a case like this, when I'm looking for something like this, then they put that on there to protect the patient. Yes, sir?
Aren't they starting to move away from shielding sometimes?
They move away from it if they're concerned that it's going to affect getting you what you want to see. And that's why, like in this pelvis, there's no shield, because this was a pelvis x-ray, right? They will still use it if they are, I don't say guaranteed, right? But if they are very confident that whatever it's gonna block is not something you're asking to evaluate. They're going away from it in pelvic x-rays, they're going away from it in like hip and stuff x-rays and certain spine x-rays and stuff, because the risk of shooting the x-ray and then you look and you're like, oh, my shield covered up part of that bone, now I gotta redo the x-ray. Now I gotta give more radiation. I don't wanna do that. So they will go away from it in those cases. They never use it for CT for the most part. Yeah, because CT is, I mean, it's coming from all angles, right? So it doesn't really help that much. But for x-ray, they'll still use it if they can. That's it. Osteopetrosis. Autosomal recessive, right? Bones become denser, bright white on all of the bones. Where's my medullary? Like, I almost can't see it on this x-ray, okay? Compared to my normal. That's it. Okay, now what about focal increase? Oh look, avascular necrosis is underlined and bolded, probably because that's the one we need to focus on. I think the other two are FYI. So focal increase, bless you, localized osteoblastic metastases. What type of imaging is this? CT, what kind of slice? Coronal, good. That might be important. Okay. So what we're seeing here, the difference from the other one is I have it on one side versus the other, right? What side is affected? Patient's left. Remember, opposite when you're looking at the image. And I said, don't get hung up on the feet towards me, head that way, because that can get confusing. X-ray and CT is always, my right is their left, my left is their right. So my right is the patient's left. That's the side that's affected. Use that, it'll save you from getting confused. All right? But yes, how do I know it's localized metastases? Well, look, it's just right there. I don't have it on the other side. Right? I also don't have it going down into the other bones. This is just localized right here. What's that? Is the patient's left. Because as I'm looking at the film, the abnormalities are on my right, which means it's the patient's left. Save this for a later class and for your clinic. Yes, sir.
Going back to that picture,
Yeah.
if you look at the femoral head on the right side, it's differently shaped.
That here?
More so the other, yeah.
Okay. So the trick with CTs is that this is one slice of many. And so sometimes if the patient's slightly rotated, it may not look exactly the same on both sides. So in order to truly evaluate whether that's an abnormality, you would need the actual CT and be able to scroll through all the images to paint that picture. So I can appreciate that you're like, well, hey, look, this is different. Here's my greater trochanter, right? It's not right here. Well, they may be shifted just a little bit. If I went a couple of slices in, that greater trochanter is gonna pop out right there. But you just can't see it on this picture. Yeah. Yes?
Can you go back to that chart? 1 second, sir.
Yeah.
Yeah.
Well, it's in your slides.
No.
Did I hide it? What?
No, just like, you want to say
It's on the PowerPoint.
If you have like the PowerPoint, don't put it in the PDF.
Oh, is that when you convert it into a PDF in one way?
Yeah, like a note taking.
Well, I put it in PowerPoint, that's what works. Using PDF. What do you think this is, the medical center next to this? Alright. Anyways, why did I put this in here? Remember how I told you see these lesions and you gotta go hunting for cancers if you're the one that finds it? Well, where do you start? Osteoblastic versus osteolytic. Again, it's not always or never, but this is where I would start, depending on what kind of lesions I'm seeing on the x-rays. If I see osteoblastic and it's an old man, I'm concerned about prostate cancer. Female, breast, male can still be breast as well, don't rule that out, male and breast tissue as well. Lymphoma or carcinoid, osteolytic lesions, I'm thinking the main cancer is lung, breast, or more concerning, that more common is gonna be your renal cell, or thyroid. So these are good places to start if you're the one who finds the abnormality on x-ray incidentally. You weren't meaning to find it, you did it for a different reason, and you saw these lesions. Okay. Avascular necrosis. Alright, results from cellular death and eventually leads to the collapse of affected bone. Wait a second, you just said cellular death, and we just talked about death meaning that I should have more radiolucency. But this is under focal increase in bone density. Why? We're gonna talk about it. Because before you end up with the bone death, you end up with sclerosis. You end up with scarring. You end up with that increase in the bone density first before it dies, because it's trying to heal itself and fix itself, but it can't. And that whole like bone death part and that radiolucent part, that is down the road. That is after you've already missed the fracture. You've already missed the issue, and it's avascular necrosis for a while now, and the bone totally dies, right? It can be asymptomatic. We're gonna look at what these look like. Scaphoid and femoral head are your two main areas. The scaphoid is gonna be more common. The femoral head, it stands out pretty easily. The scaphoid one is the one that'll be very difficult to kind of see. Fallen outstretched hand, right? And we'll talk about what that plan looks like for those patients and make sure you don't miss it. Because if this bone dies, there's no bringing it back. It's dead, okay? What it's due to the blood flow, and we'll talk about it. X-ray is your initial study. So now here's where we finally start getting into things, right? Yellow in almost all of my slides is the initial study. What does initial study mean? It means a study on ordering first. Even if I know this is avascular necrosis, I'm ordering an X-ray. That is the initial study. MRI is the study of choice. That's in blue. Study of choice or definitive study, interchangeable. That's the study that if I want a true definitive diagnosis, I'm going to order that study. But the X-ray will be first. Now the question you're going to ask me is like, why don't I just jump straight to an MRI? Well, A, it's more expensive. B, it's going to take them weeks to get in. And C, it's a much longer exam. I could send you for X-ray and have you back in 20 minutes and possibly look at it and figure out if you have this or not. Right? So X-ray is initial study. MRI is a study of choice. X-ray is also more readily available than MRI, which is another reason why we still do those. Okay? We're going to start with the femoral head. The one on the left is normal. The image on the right is abnormal. And my head is squished. Right there. So what happened here is there was a small fracture in the femoral head. This is a later picture. What happened here is a small fracture in the femoral head. It was overlooked and missed. So the area of, I'll do it on the this hip here, the area here lost their blood flow, right? It didn't get it. So it did first start to sclerose a little bit, and then it crushed down. Why did it crush down? Because it's weight bearing, right? There's no bone there to support that, so it eventually just kind of collapsed on itself as that bone eventually died. So focal increase due to the fact that you can see this is more focally increased as far as a radiopaque compared to the other side, right? So this is where when you have an abnormal pelvis x-ray, you compare one side to the other to help you see that kind of stand out a little bit, right? Right there versus it's not that bright there, not as radiopaque. And on top of that, you're probably gonna have some patient history and some patient symptoms, right? I.e. some hip pain going on for quite a while. Or I have one of these things that increase my risk of avascular necrosis. I have sickle cell disease. I have polycythemia vera, right? You'll learn what polycythemia vera is, right? Trauma fractures, that's mostly what we're gonna talk about here. Chronic alcoholism, rheumatoid arthritis we will talk about. Renal failure. This STARS acronym is a good way to try to remember things that increase the risk of avascular necrosis in your patients. Now for this course, there's going to be some type of injury for this, right? Some type of injury to the wrist or to the hip to make you think that maybe the x-ray, and then you're kind of like, is this something that's avascular necrosis? I don't really know. Well, besides the trauma, can I give you anything else to go with that? To help you lead down towards that route? I don't know, maybe, right? Vignette will be helpful sometimes. So just understand these are the types of patients that you can end up with avascular necrosis on. Yes, sir?
What is SLE, sir?
Say again?
SLE.
Oh, sorry, yeah, SLE is lupus. Systemic lupus erythematous, I believe is the actual breakdown of it. You know, that diagnosis in house that it's never, but they always try to work it up. I think there was one episode where it was actually lupus, like 9 seasons. So here it is on the scaphoid. Here's the catch with avascular necrosis, okay? This is one of the few times. That left x-ray is not normal, okay? It is not normal. So there's a big purple circle around it. However, the fractures, the avascular necrosis is easily overlooked on x-ray. They can be so fine sometimes that you do your thing, you're like, everything looks good. Except for that small little cortex break right there. I'm gonna erase it, let you look at it again. And when I trace my cortex around, oh, there's a radiolucent line right there. Do you see it now that I pointed out? If the answer is no, that's okay. Because that's, yes, sir.
I'm sorry, I keep looking, sir.
That's what, no, that's what I'm here for. You buddy.
So on the opposite side from where you have the cortical break, it almost looks like to me at least, treatment break guys. It almost looks like there's a little bit extra radiolucence right there. Is that correlated with that cortical break?
Got it. So there is some, this is where that focal, sorry, you said radiolucent, you mean radiopaque?
Yes, that's what I meant.
Okay, this is where that focal increase in density comes in. What we have is this small radio-opaque area compared to the surrounding medullary bone, right? That is a little bit brighter. Why is that? That's the start of that scarring from the avascular necrosis. That's the early stages. This can often be overlooked. You're not wrong if you overlook this, okay? If you miss this on x-ray, the purple circle, that's okay. As long as you tell the patient whose wrist hurts that the x-ray looks normal, and if it's not better in 7 to 10 days, I need you to come back so we can x-ray it again. If you don't tell them that, you're wrong. And that's a bad day. But if you say, hey, come back in 7 to 10 days if the pain's not gone. Because if this is an avascular necrosis, that pain is not going away. They come back in 7 to 10 days, you redo that x-ray, it may be as bad as the red arrow one. Yes, sir.
Yes, sir, so it's not the divot, or that like little indentation
Here?
there. It's just the fact that that's more radio
So it's both. There's a small fracture in the cortex right here. Very small fracture in the cortex right here. It's minuscule. I don't want you guys to get hung up if you can't see it. I chose this one intentionally because it was really hard to see. And if you don't see it, to tell you it's okay if you miss it as long as you give that follow-up for them to come back, right? So it's okay. And there's a small radial opaqueness there as well. That's what's showing me the avascular necrosis. If you miss it, it's okay as long as they come back because you'll redo the x-ray. And that fracture that's hard to see right now will probably be more prevalent because the swelling has gone down, it's had more time to kind of have an effect, and now it's there on the x-ray. If the x-ray is normal again, you give them the same counseling. Yeah, still looks good. It's still bothering you 7 to 10 days, come on back. Then if they come back and it's still bothering them, now you're getting the MRI. You've tried 2 x-rays, hasn't gotten better, you haven't seen anything, you know they're tender over that scaphoid because you do your physical exam. Now I'm going to study your choice. Why? Because I need to know for sure. Because if you miss a scaphoid fracture and cause avascular necrosis, that bone is dead. If you catch it early, ortho can do surgery and save that bone. And that's why we need to know.
What time frame is it early enough for the fracture to come back?
What I just told you. So as soon as you see it, you'll go to ortho, but like, there's no, like, I'm not talking like 5 weeks, like what the time frame would be, right? They come back in like a week, week and a half, x-ray's normal, come back in another week, week and a half, so now we're at like 2 to 3 weeks, x-ray's normal, I order the MRI, maybe the MRI's in like 3 weeks. Really what I would do in this case is I would call radiology and go, I have concern for possibly vascular necrosis, how soon can you get them in, right? Maybe it'll be like in a week instead of 3, but even if we're looking at 2 or 3 weeks versus 6 weeks, still early enough to be able to save the bone. It's the ones that don't have them come back and they just never come back and then it's like months later that they show up, that's where we've had the issue. Ortho will talk more specific timelines, right? But in this case, again, I would pick up the phone and call radiology. I wouldn't make them wait the 3 weeks, I'd just say, what can you get it in for? I need to make sure.
Why would you wait for 2 scans before ordering the right? So just, they come back a week later, and it's like, it still hurts, it's the same, alright.
Because of the fact that, again, the MRI is super expensive, right? And it's gonna take time to go ahead and get it. And honestly, anecdotally, right, 90% of the time, the x-ray is gonna be abnormal on that second one anyways. It's gonna be on, it's just the standard of kind of like, you do it once, come back in 2 weeks, do the x-ray again, let's still see if it gets better. So, or if they may have a different, like, I would do it right away, I'm gonna tell you your MRI stuff, and just, at least do the second x-ray, and kind of go from there. Because they can fix it. But you may not see it on normal x-ray. But scaphoid and femoral head, right? What else we got? Here's another example. So this is kind of showing you, okay, the x-ray versus the MRI. Showing you the x-ray versus the MRI. I got my scaphoid here, normal. I can see the fracture there, so we're good. Plus I have arrows, right? But look at the MRI, look at the detail it has right there. Just that little bit of increased frequency for that scaphoid bone, that's what's gonna kind of show you what's going on with that. And sometimes if it's already starting to die, you'll start to see like some more like frequency kind of sitting in there, like the inflammation is coming from the dead bone. It's all because of that blood flow. We'll go over it again when we get to the upper extremity, and we'll have some more pictures of it so you guys have a solid grasp of it before we get there. Both lower extremity, upper extremity slideshows towards the end of this block. We cover the femoral head avascular necrosis again, and we cover the scaphoid avascular necrosis again. This is just introducing it. But just remember, it is a focalized increase in density. Why? Because that's scarring. That sclerotic bone that shows up first, then the bone dies. We want you to catch it before the bone dies. Paget's disease, okay, I'll probably end with this. So, Paget's disease is a focal bone reabsorption and disordered bone formation. primarily in the pelvis and the spine, okay? You notice how x-ray is blue? That's because that's the only study for this stuff. There is no better study. X-ray is what you're gonna do. Sure, you can get a bone scan to further delineate, but you don't need to. X-ray is going to diagnose this, all right? Asymptomatic in 70% of the patients, but then pain in 74% of the patients. What the heck does that mean? Hang on. What that means is, of the patients that are symptomatic, pain is the most common symptom, right? So, of the 30% of patients that are actually symptomatic, 74% of those have pain as their most common symptom. That's kind of what that means on that slide. That's what it looks like. Okay? You will see Paget's again in pediatrics. That's why I'm showing you the pictures. So when you see that, you will see Paget's. What makes it a focalized increase in bone density? It's the focal thickening of the cortex on the back end. So here, and then also here, you can see how thick the cortex is compared to my normal on this side, right? Look at the thickness of the cortex on this one compared to this one. Same thing here on this one compared to the thickness of the cortex there. So that right there is one side, and then the trabecular pattern is really accentuated as well. The bone is basically getting larger due to the Paget's. Pediatric disorder, you'll learn it more senior semester, but it won't be the first time you see it. And then here are your slides to make sure you know your chart, right? I am only going to test you on the ones that I said are testable, which, oh, shocker, was one in each category for right now. Okay? So, know what it looks like, or really save this to go back to before ortho, before peds, so that way when they pull it up, they're gonna blow right past it, you at least know what it looks like. Tomorrow, we will start calling over generalized decrease in bone density, localized decrease in bone density, everybody's favorite osteoporosis. Questions on what we covered today? Look, I didn't do that thing where like you call the instructor in early and then like he still goes till 3 o'clock. Have you had that yet happen in the program? Yes. Did you have a question, sir? You have a question? You sure? Go for it.
Osteoporosis, it also causes an increase in generalized decrease?
So osteoporosis is strictly going to be a generalized decrease in bone density. What happens with osteoporosis, and we'll talk about it more next time, is because of the decrease of bone density, it makes the cortex look like it's increased, but it's really just because of the relationship of something. It's like if you put two colors next to each other, it looks this way one way, and then when I set it next to another color, it looks kind of different. It's just more in relationship to it. We can talk more about it. Yes, that's okay. Petrosis increase, hardening, porosis we'll talk about tomorrow, decrease because the trabecular bone pattern